epidemiologic revolution that started from Chennai. And wonderful speaker, Dr. Ramachandran.
Yep. Thank you. Can I have the slides on? Before I start talking, first of all, let me congratulate Krishna for one more successful debate meeting. Fantastic organization. Shashank has given you all the new trials on the basal insulin. So a couple of statements which I'm going to make on the insulin space research. The introduction of glargine basal analog insulin in 2002 by Sanofi has been the second most important discovery in the insulin space after 1922, for the simple reason that has actually revolutionized insulin therapy in the world. After the introduction of glargine basal analog, the prescriptions of insulin went up almost 50% within a year in the United States. The reason being that there was more confidence and conviction on the parts of physicians to use insulin in a much more liberal way because of the less hypoglycemia. So in my talk, this is a company-sponsored symposium. These are my disclosures, just to make sure. So this is the story I'm going to take you through. Glargine is not new, but there may be questions how to start. Even today, although we talk so much about insulin, and insulin is one of the best molecules for treatment of diabetes, we have still suboptimal control of diabetes. And I'll show you some of the studies. I'll put in some of the studies in between so that there'll be some masala in the talk. First is basal insulin initiation. All the regulatory bodies have given us some of the ways how to start, guidelines. The IDF in 2017 has shown that you can start with 0.2 units and then go twice weekly by 1 to 2 units depending upon. So you look at the fasting plasma glucose and aim it to be between 70 to 130. That is the target. The ADA said, again, you start at 10 units and then you can, that's about 0.1 to 0.2. So if your weight is more, it'll have more insulin, and then depending upon the degree of hyperglycemia, you keep increasing. The RSSDA, which is we are a part, Shashank is a main person in that, basal insulin alone or a combination with metformin is the most convenient insulin, and they're also given the doses which one to start with as a guideline, which I'll give you momentarily. Before telling you that, now has the insulin use increased or not? I was involved in this study called the Trends in Treatment of Diabetes, a global study just published 1.5 years ago. We took a large number of patients in 2006 and 2015 from 10 clinical services in 9 countries. See the numbers. We had 4.5 million patients, so we used actually a machine learning technique in order to do the among these, more than 90% were actually categorized type 2 diabetes. And what I'm going to show you here is in a global way, other than we keep talking about always United States. Other than United States and United Kingdom, Western Europe, we have the data on this. And what we found is that there has been a substantial increase in the use of insulin, which is a good news. So the treatment of people with type 2 diabetes with insulin has increased substantially from almost 10% to almost 30% now. It is almost about 19%, we have 30%. We have specific data on India, which I will not be talking today. Now, can initial basal insulin therapy change the natural history of type 2 diabetes? We are always used to reading the textbook and say, diabetes is a progressive disorder. And whatever be the strategy of treatment that you use, there is always a decline, and that the HbA1c keeps climbing up and climbing up. And so all the time we think that we don't have the right drugs, or we also blame the patient, and probably we feel, I don't know whom to blame. So if you look at the UKPDS, which is the famous study, every time you see that, and you see that irrespective of whether you used insulin, chlorpropamide, glibenclamide, there was a deterioration. If you look at the ADOPT study, which also had glyburide, metformin, and rosiglitazone, it showed the same thing. So the textbook wrote the sentence that diabetes is a progressive disorder. Whatever the treatment you give, they become worsened, and after some time, you have to give the insulin. But the story has changed. I think you have to rewrite the textbooks from this study, and this is called the origin trial. Why I'm putting this is because it is relevant here because I'm talking about glargine. In this study, insulin glargine was started at a very early stage in the natural history of type 2 diabetes. All these patients were either were drug naive or they were only on a single anti-diabetic agent. And then you started with an HbA1c of 6.4, and after 7 years ended up with 6.2 in the intervention group, which is actually the other way. So we have reversed the progression of the exhaustion of the beta cells by using glargine insulin at an early stage of type 2 diabetes. So if you have the right tools and the right strategy and the right approach, probably you can remit diabetes. We can go into remission of diabetes. So after that study, the guidelines were rewritten, and the concept of early basal insulin got into the guidelines after the origin trial. That's why I said it is actually a game changer in the insulin space as far as type 2 diabetes is concerned. And only thing is that you cannot just close your eyes and give insulin. We could close the eyes in the beginning and give because it doesn't produce so much of hypoglycemia. You see, Shashank was talking about all the trials of the new insulins. When you introduce glargine from the old NPH, the step that we took was almost 10 steps more because we could use insulin much boldly without producing hypoglycemia. But the steps which have taken after the introduction of the other analogs which have come, even glargine 300, IDAC, the gludac, etc., is only maybe 2 more steps than the glargine 100. We are not taking a bigger step, much bigger step. So the difference between the original 100 glargine and the newer ones are much less compared to the difference that you gained between the old NPH and the glargine 100 in 2002. Well, when you start the insulin, it doesn't fit all. As I told you, you can use the formula, but for those patients who are, usually we have 60 here, and 80 means much more, and 100. So that's just a guideline, but always every patient is different. Now, we have learned this number actually from the origin trial. In the origin trial, the target fasting plasma glucose was 95, not even 100. And we attained that in 60% of patients. So if we started with we ended up with 0.3 at the end of 1 year, and by 6 years it is 0.4. So people can tolerate a large amount of glargine, and that is without much of hypoglycemia. So from this, if you can calculate the dose, the maximum dose, or the right dose that you probably have to use in a 60 kilogram person in India would be about 24 units per day with glargine. Okay, now coming to the titration, of course, one of the problems that we do not titrate, we have to up-titrate the insulin in order to actually meet the target of less than 100, so it has to be done. Why are we not aggressive from the beginning? This is my own concept. We are all people treating diabetes day in and day out. And when patients come to you, the average plasma glucose of patients who are attending the clinics in this part of the world is definitely more than 8. So we are suboptimally treating diabetes. I'm not talking about newly detected, talking about people who are treated. It's almost 9. One of the things the way we have the problem is that there's a lack of predictable response to an available drug. We don't know which drug is the right drug for the patient sitting in front of you. There's a difficulty in balancing lifestyle modification and drug doses, because the patient is on a good diet, doing exercise every day, he will go into hypoglycemia. But when he's got a lot of weddings and a lot of Deepavalis and etc. coming, then the sugar is high, and then you increase the dose. Once patient comes to the clinic and you increase the dose, the patient also becomes very careful, and there is a reinforcement for his lifestyle modification. Then he goes into hypoglycemia. So you have this problem of balancing the dose of drugs and lifestyle modification. However, that has changed lately because of the introduction of newer agents. The fear of side effects like hypoglycemia, lack of immediate demonstrable benefits from aggressive treatment. If somebody has a 250 milligrams blood glucose and is comfortable sitting in front of you, you want to tell him, oh, you're not all right. I want to bring it down to 160 postprandial. Now, what is the benefit that you and the patient deriving from that from tomorrow? Nothing much. That's one reason why we are not aggressive, because there is no immediate demonstrable benefit. I don't know how many patients will thank you on the phone and say, oh, my blood glucose has come to 160 because I saw you yesterday. They don't do that. Lastly, there's a lack of certainty about the prevention of complications. But because we know that even with the tight glycemic control, we are not able to really reduce relative risk reduction in the control of complications, much less you have to look at other parameters like blood pressure, dyslipidemia, weight, and using antiplatelet agents. So it has changed. The introduction of the newer drugs, including the basal analog glargine, has probably, to a large extent, changed these concepts. Why the insulin titration inertia? This is the inertia which I told you about aggressive therapy. Specifically for insulin, it is difficult to integrate insulin into somebody's life, and titration algorithm may be difficult for people, and many patients think this is increasing the dose of insulin is not good for me. Insulin probably injections are not good for me. So there is always a failure to up-titrate insulin. So insulin without producing hypoglycemia, the need of the hour, and you know, this is the first study done by Raskin from Dallas, who showed that NPH and we are using premixed. 60% of our prescriptions in India are premixed, but look at this, between premixed and glargine, there's a substantial difference in the risk of hypoglycemia. On the right-hand side is actually the difference in hypoglycemia. I think the new insulins have not improved the frequency of hypoglycemia as much we want, and that's what Shashank showed you earlier. What are the recommendations for basal titration? You target fasting when you give basal insulin to 100 or below. Of course, you can actually target between 70 to 130 milligrams, and you can keep increasing. There are so many ways. Oh, what happened? Is it locked? Computer person up. You have to look at the fasting plasma glucose, and then you make a change in the dose of insulin and wait for at least 2 to 3 days. In the Origin trial, when we are looking at the fasting plasma glucose, the patient was doing fasting plasma glucose at home every day for 7 years. And then patients were asked to target below 95 fasting plasma glucose at home. We increased 2 units per week in order to do it. And then we increased to 3 units, and then finally we went up to 4 units per week, and because there was no fear of hypoglycemia. What is shown here is one of the recommendations from what is called the B-SMART study, and the more relevant probably will be the RSSDI, which Shashank is sitting here. You know, you can look at the HbA1c and look at the, if the HbA1c is more than 8, you can use 0.2 to 0.3. You can even go to 0.4. And if the fasting plasma glucose is high, that is the algorithm. 4 units, 2 units, or 1 unit, if it's 180, 140, or 139. And of course, if the monitor of hypoglycemia comes, you could reduce it by 10 to 20%. Use your trial and error, use your own judgment in many a time. Why should you intensify treatment? I just told you why we are not aggressive. There's a very nice study from the United Kingdom showing that almost like a legacy effect. Now here it is a negative legacy effect. What is shown is that does the delay in the intensifying treatment cause complications in the lung? This is from the NHS data. Delays in treatment intensification may very well put patients at a higher risk of complications. They have tested whether a 6 months delay in intensifying treatment could produce complications from the NHS database. Very interesting. And what you can see here is that a 6 months delay, years before, after 20 years, can increase the risk of cardiovascular disease by 20% and myocardial infarction by 26%. I think it's a biggie. So if you are not actually reaching the targets, we are doing an injustice to the patient. Patient does not know these figures. So results provide a strong therapeutic rationale for early intensification of therapy in patient type 2 diabetes to prevent macrovascular complications in this case. Well, empowering patients, you can also empower patients. This is again a study not from India, but we also have an Indian study called which I'm going to show in the next slide, that whether the clinician or the patient, there is no difference in the target achievement. This is the ATLAS study, which is done in India, showing that you don't have to say, oh, Indians are indisciplined people. Even in India, self-empowerment can work. About 20 years ago, when we were talking about self-empowerment, we were thinking that we were not able to do that in India. Patients always had to come to the physician for adjusting the dose of drugs, but we can do that yourself. Digital tools, of course, you can use mobile phones, and this is one of the studies which have been done. And in fact, there is a MyStar dose coach support, which actually has proved to be actually superior in actually reaching the target in patient using the web, the app in the web, which can actually, you can see that using this app can actually give you guidelines and instructions to improve your control of diabetes by using the app. At this point, I want to give you one example. You may remember that we published a paper on using SMS in the mobile phones for prevention of diabetes. And many people ask me the question whether you can use mobile phones to improve treatment of diabetes. So we did a study very, very recently. In 2011, the WHO said that the use of mobile and wireless technologies to support the achievement of health objectives, called the mHealth, has the potential to transform the face of health service delivery across the globe. That is the time we actually published our paper on SMS for a clinical outcome of prevention of type 2 diabetes. 3 months ago, we published this paper. This is called the use of mobile phones in diabetes, called the M-diabetes. Can mobile phones can be used to improve management of diabetes? So what we did was, we recruited newly diagnosed diabetic patients from 2 states, Tamil Nadu and Andhra. I think there are about 6 centers. This is a multi-centric randomized control trial conducted in 2 states, and the primary outcome was improvement in glycemia measured by HbA1c and plasma glucose levels. So that was the trial. 121 patients were receiving this. We told the physicians, you give the usual treatment, but we are randomizing them 1-to-1 in your clinic. One of them will be getting an SMS from a server from Chennai every 3 days, 2 times a week, in order to adhere to the diet, improve dietary modifications and also exercise, etc. And wanted to see how it can actually achieve better control. But this is the results. In the beginning, you can see the HbA1c was 9.5. That reminds me, what is the average HbA1c of newly detected diabetes in India? It's 9.5. We're writing a new paper on that. So it's pretty late diagnosis. It's about 8.1 in the United States. Over the 3rd month, 6th month, 12th month, 18 months, a very well done studies, a randomized control. Now you can see both of them, it came down from 9.5. In the control group, it came down from 9.5 to 7.8. And in the intervention, it came down from 9.5 to 7.4, which again was statistically significant. The difference is only 0.4, but it was statistically significant. You can also see the fasting plasma glucose came down in the controlled group from 11.5 millimoles to 8.4, which is 153, and from 10.9 in the intervention to 7.5, which is 135. So in a graphical way, you can see that it's 0.044. The difference is, it is 7.8 and 7.4. Here it is 135 and 150. So we did another multi-logist regression, which said that the intervention was actually the odds ratio 1.7 now. So it looks as if it's a good tool, and we did it for 2 years, and it can be used. So we can use the information technology or mobile phones to improve treatment, and also to adjust the dose of insulin and intensify the treatment so that patients can actually achieve their targets within a short period of time without much of effort. So to summarize, early initiation and optimization of insulin glargine will result in reduction in fasting and postprandial sugar levels, reduction in HbA1c, and of course greater quality of life and satisfaction. Evidence from all these studies have also shown that you can actually target less than 100 milligrams fasting. So the key message is that basal insulin dose titration is very important. Dose titration is specific and should be absolutely individualized, and it's actually gives some flexibility and improve life, quality of life in patients with type 2 diabetes. Thank you.
Shashank, why don't you come? We have good time for questions, so please, for those of you who don't want to use the app, can I have the tab? We have traditional question papers. It's in your book. We also have papers handed out to you. Please use them. And we have a good number of time, and we don't get these two guys captive on the stage for a long time. So now's our chance to really make use of these guys. So here's the first salvo. Let me start off with Shashank. It's my own question. So Shashank, when would you consider starting someone on a low volume insulin versus switching? I think there's a lot of question whether should you be starting someone right off the bat on a low volume insulin, or should you use a U100 and then switch?
So I think the answer is very simple. If the patient can afford, I will directly start.
Okay. All right, Dr. Ramachandran, first question. Early insulin, maybe you could start off with the remission issues and please keep the questions coming. It's very rare we get these two guys on the stage together.
I think Shashank put this number. He said insulin has been used for diabetes for 100 years. So that is the safest molecule that you can use. It's not that you cannot use other drugs. And what Krishna just asked me is remission. That reminds me, yesterday I got a letter from the BMJ. We are writing an article on with Roy Taylor on remission. You know, the Roy Taylor has published the data on remission in type 2 diabetes. You can achieve a remission in type 2 diabetes in many ways. One way is that if somebody is very obese and has got only mild diabetes, make him lose weight, you remit diabetes completely. The other thing is that you actually treat diabetes very intensively from the beginning at an early stage when the beta cells still have a lot of secretory capacity. And one of the best ways of actually removing glucose toxicity is to start insulin early. And there have been a couple of studies to show that if you start insulin very early, and then even when you can withdraw, you can achieve remission. Mind you, when you talk about remission, you should achieve a fasting plasma glucose below 100 milligrams, or at least below 110 milligrams, without any drug. And that is remission, and it is possible.
So if you take the Weng data, they used multiple doses of insulin. On the other hand, the Origin showed that if you start off with small doses, you actually persist over a period of time. Maybe both of you can comment on this.
Well, Origin is a different cup of tea. I mean, of course, Origin, we are not looking at remission. We are talking about what, it is a cardiovascular trial. What I am trying to impress upon you was actually how it is not a progressive disorder, but came to 6.2. We are not thinking of remission there. We didn't achieve remission because patient already become older and went for 7 years. Wang's study was different. It was a very short study where he actually completely removed glucose toxicity by giving continuously insulin, more aggressive therapy, and then stopped the treatment completely. And after 1 year later, found that those patients who were treated more intensively with insulin attained remission because he gave beta cell rest.
So I think what Professor Ramachandran has said is very right. See, two things we need to recognize, that we are next year celebrating 100 years of insulin discovery. And I think the longest surviving anti-diabetic drug on planet Earth is insulin. It is the safest, it is the easiest to use, it is the easiest to titrate. Unfortunately, it has the highest negative connotation of perception. And I think our portal vein has insulin, our glucose in our body is regulated by insulin, and therefore, if your duration of diabetes is 2 years or less, you have glucotoxicity with uncontrolled hyperglycemia with osmotic symptoms, giving beta cells rest with insulin is very logical. And I think that's something which is the order of the day, and after that a patient can be in remission for a long time. So I think that has been achieved first by Japanese authors, almost 2 decades back. And the Chinese authors and the Korean authors replicated that, but they had better insulin delivery models. But I personally feel that if you see any type 2 diabetic whose duration of diabetes is less than 10 years, fasting PP may be, anywhere in 200s and 300s, in A1C at 9 or 10, you give them good insulinization, give them good rest for a short duration of time in 3 months to 6 months with appropriate lifestyle, you actually can see a lot of remission in that situation also. I don't think we need to do what Roy Taylor did in a different situation, which is like hypocaloric diet. With good insulin therapy, you actually can achieve remission in the same way. Maybe Ramu has a comment on that.
I just want to say, do you know when the first paper on remission was published in India? It was back in 1979, 1980. Dr. Vishwanath was the first author. We published a paper, we had a journal called Journal of Diabetic Association of India. And for the first time we published cases of remission in type 2 diabetes. Nobody knew what is remission at the time. And the definition was, you do an oral glucose tolerance test, it should be normal, and patient should have had diabetes at least a year before that. Okay.
So we have a question. What is the maximum dose we can give basal insulin? I also want you to sort of add on to this. Just a lot of people talk about twice a day basal insulin. No, I'm talking about Rajin and the others. So maybe you can start taking this in.
When Rosenstock did the first studies with Glargine and also with Determine, one of the things that he found was that if the dose goes above 40 units or 50 units in the American population, when you divide into 2 times, they had a better control of total diurnal variation and hypoglycemia. So that is the first thing that they said, even though we claim that it was for 24 hours, it was only 18 hours, so Glargine can be used if the dose is very high 2 times a day. You asked the first question, how much should be what is the highest dose of insulin to be used? I just reminded, 1983 I was working in the US, we had patients with very high insulin resistance giving 1,500 units a day. The problem at that time was not the insulin molecule, but at that time we had the preservative called phenol. So we called Lilly at the time because that is and they said, be careful because the amount of phenol they're injecting into the body is too high. So there can be phenol toxicity. I'm just reminded of that. Otherwise, insulin molecule will not have any risk at all if you're using high doses.
So extending pharmacological insulin resistance by definition is more than 200 units a day. I am not a big fan of using insulin basal twice a day, unless and until it's NPH. And if it is not NPH, I think you should use it once a day. A lot of people tend to use insulin at night because it controls overnight hepatic glucose production. It controls the fasting. So it is more physiological to use it at night than to use it during daytime. But there is no hard and fast rule. I agree with Dr. Ramachandran that for convenience sake, anything more than 30 or 40 units got split into twice a day. Okay, Detimir probably is the only insulin in the modern space which can be used twice a day, but otherwise all the insulins should be used once a day. Modern insulins so should be definitely used once a day only, and I really am not a great fan of using it twice a day, at least the basal part of it.
Thank you. So now with this big interest in both low carbs, paleo, and now intermittent fasting, can you both comment on insulin dose and modifications during?
All those Marwadi patients were doing
So these are fad diets which are not evidence-based. Though you might have a very nice paper in New England Journal of Medicine on intermittent fasting, you see it becomes very tardy. If somebody needs insulin on board and is doing intermittent fasting, it can be extremely hazardous and detrimental. And I think one yardstick which I tell all my patients who do crazy diets or fad diets or popular diets, whatever you may call them as, on insulin, first get your basal C-peptide on board. If you have adequate beta cell reserve, you can still tinker with your health. But if you don't have adequate beta cell on board, you have no right to do any of these crazy diets. So that's the first principle. Primum non nocere, do no harm. And I think in insulin symposium, we should not be discussing all these diets. Okay, because I think when you are using insulin, I would discourage my patient to use it. All I would say is learn a little bit carb counting, try to have mid-meal snacks, ensure that there's a bedtime snack to avoid the nocturnal hypoglycemia. You have these modern day, meal replacement supplements, like we have some of these ensure diabetes care type of situations or OptiFast, which can actually prevent nocturnal hypoglycemia. That is far more useful than doing any of these crazy diets, because I think what happens is that we also have molecules now, either once a week or once a day, which is in the GLP-1 table, which can be very efficiently combined with insulin and cause that weight loss which we desire, can be protective to the heart. And therefore, I think we need to be very cautious about some of these modern day diets. In somebody who's not on insulin, maybe on 1 or 2 agents, A1C is around 8. You want to try any of these diets, it's okay. But somebody's crossed in A1C above 9, is already on insulin on board, I think I will not use any of these diets. That's my clinical recommendation.
So I'm going to switch gears a little and move to patient empowerment, because that's some of the biggest parts, and I'm sure people have also questions on this. So which do you think works better, a physician-led titration, or do you think patient-led titration? How do you empower patients? I know you've given a talk, and both of you are very, very patient-centric in your approaches. I'd like to see you, to hear your personal experiences with this, good, bad, ugly.
I think I'd still support patient empowered and try to, reduce the load on the physicians. Physicians are actually not good people to actually, the patient knows better. They will give you the answer. Many a time, I think, having worked for the last 30 to 40 years in diabetes, I feel that listening to the patients, they will give the answers to their problems. Then you try to, please listen. And he will say, my sugar has gone up. I am taking 30 units of insulin, but last week this happened, then I reduced to 20 units, then I had one a party, then I reduced to 20 units, now I am taking 24 units, my sugar is under control. So just listen, okay? Then you continue 24 units. You don't have to do anything at all. So most of the time, they know the answers if they're already on insulin, because they know what they're eating, they know what they're doing. You can always give guidelines, you can always help. You have all those 0.2 units per kilogram, 0.1 unit. It is not one shirt which fits all everybody. Everybody is different. So I think I'll support patient empowerment as much.
So I think I completely agree with Dr. Ramachandran. It's patient empowerment, patient empowerment, patient empowerment. But I have a small 2 caveats to that. First is literacy. I see that there is an important tenet that we see, and the system in which you are seeing the patient. So if you are seeing in a large public health hospital OPD, a patient where the doctor to patient interaction time is more of a prescription generation in a less than 30 seconds or 1 minute, and no backup of educator, probably in that scenario, and there is a lot of ignorance and lack of education, a physician driven titration is much easier. While if you're looking at a private scenario where patients and doctors have adequate time for interaction, I think it is all patient empowerment. And it is directly proportional to the doctor and his team spending the time with that patient. The more time you spend, the more empowered the patient is, more educated he is to make a decision on insulin titration. It's all about education, and if I think, that's where it centers around.
Just to extend this further, when does technology come into this? I'm sure at some point of time, do you start off with let's say I'm starting insulin today, and you started me on 10 or 12 units of insulin. Do I also go home with a titration algorithm in your practice, or do you say, you know what, I'm going to give you 10, 12 units, but come back in a month, and then we'll help you titrate? How do you gauge this? How do you work this?
So I think technology is very good as an aid, as a support service backed up by a human face. If there is no human touch to technology, it is disastrous. So remember that all technologies need a back end which is very good, and some of the supports the educator backends and technologies are giving is excellent. So it is important that technology, whenever you are adding a gadget, it takes time. If you are downloading ad on your phone, it takes time. So it's a learning curve. So I personally feel that you still need a human interface as a backup for the reassurance. If it is just a computer or an AI adjusting my insulin dose, I don't think any patient is comfortable. They want to know that somebody from your team with that digital support I have is there for me available. And that is something that is to conquer the fear factor in the mind of our patients. Our patients have a unwritten fear that something might go wrong with this injection. That fear is not there with a tablet. They might be taking a good old glibenclamide, which can cause fatal hypoglycemia, but they still are very, they don't have that seriousness of that hypoglycemia. But if they are taking an injectable, they have that inbuilt fear, and that's something which they need to recognize can be overcome by digitally empowered and backed up team. And if you don't have that, it's a disaster.
I fully support that, and there are almost 20,000 apps in diabetes. The point is that apps definitely help you, support you, and complements you. But there is a very high rate of attrition of the use. Any of the new apps that you download for exercise or food, or you use it very well for the first 1 month, 2 months, 3 months, and there's an attrition rate. So therefore you need what is called continuous motivation reinforcement. And as Shashank just now said, you need probably the backup, the human element in that, so that people continue to use that and get the support on a regular basis.
So in your practice, does titration start on day one with the patient, or does it take time?
A week, at least a week's time.
In a week's time, you start up titration. So I'm sort of going to wrap it up with both of you making comments. A lot of times when new insulins come, when new things come, you expect something to change dramatically, and then people start questioning it. But you both have been seeing trends for years. I remember the time glargine was introduced, and all these incremental changes that have occurred. In your view, in your personal view, have these new insulins how much have they impacted patient care? In your own practices, have you found safety increased? Have you found adoption increased? I'd like a personal view from both of you, because both of you bring the kind of wisdom and knowledge that very few in the country have.
There's no doubt. I just said in 2002, when glargine was introduced, the prescription rates have gone up very high all over the world, not only in the United States. And we have data from non-European and non-American countries now that the prescriptions of insulin has gone up very high. And one of the reasons have been that you have this basal analogs, which does not have high risk of hypoglycemia. We are right now looking at the data here and looking at the insulin use, and we have found there's a number of factors we are looking at, the trends in clinical profile and also the treatment. And one of the things that we have found is the use of insulin has substantially gone up. There's no doubt about that. The proportion of people getting insulin. I'm not going to give you the numbers because they're still writing the paper. I think we have seen the change. It's a big difference. And the other one is, all over the world, there has been multiple complexity of treatment has increased. In other words, patients who have been taking only metformin and sulfonylurea was higher proportion earlier. Now you have more number of patients who are actually using multiple drugs. For two reasons, the lifespan of people with type 2 diabetes has increased over the years, and the prevalence of diabetes has gone up all over the world. So the complexity of treatment has increased. I don't want to tell you the bad news. The bad news, of course, is that over the years, the last 10 years, the overall HbA1c has not improved. However, the rates of complications have improved substantially, and that is because the use of statins, ARBs, treatment of hypertension, dyslipidemia, and the use of antiplatelet agents have considerably increased, and that has reduced the total event rates of complications. So there is good news and bad news, but I think more good news.
So I think 3 things we need to recognize. When I was in medical school 3.5 decades back, one thing was very clear cut, that it was metformin or fenformin, it was chloropropamide or glibenclamide, and insulin. And as Dr. Ramachandran said, treatment of diabetes was very simple. There were 2 classes, biguanide class and a sulfonylurea class, and insulin. And I think from then till date, probably 3 decades back, every 7 seconds one diabetic was dying, or probably every 10 seconds a diabetic was dying. Today, every 7 seconds a diabetic is dying. So from mortality standpoint, nothing has changed. And as he said, now things have become very, very complicated. Because people use insulin, unfortunately, as a last resort. They should be using insulin much earlier. Insulin has got onto a back burner now, because people are using one agent, second agent, third agent, fourth agent, alternative agent, anything but insulin, which is wrong. Many people who need insulin don't get it. Many people who don't need insulin get it. That's the second challenge. What has happened in the insulin space is we are getting better insulins, lesser hypoglycemic insulins, and lesser weight gain insulins with a lot of data of its CV neutrality and large outcome trials. And I think the GLP-1 agents coming in the insulin space also has not helped insulin in general. So as we near a century of insulin use, I think kind of, except for complications for which none of these agents are directly responsible, I think things have not really been brighter. And I think still we have a long way to go. And I think India and China and across Asia now, we are a grossly under-insulinized world. And that is something which we need to do a change and a shift.
So on that bright note, I think I'll conclude with just this. And I can see Sai smiling because two things he wanted in this meeting are in. I think 100 years ago, insulin came as a promise. But unfortunately, many of us started using it as a threat. We tell our patient, it's the old Buchandi story. You know, if you do this, this will happen to you. If you don't do this, it will happen to you. If you don't take your diet, we'll be on insulin. If you don't eat on time, you will be on insulin. If you eat this, you'll be on insulin. We started using insulin as a threat. And to this day, our patients perceive it as a threat. I think it's also one of the reasons that these symposia are kept is because we need to start promoting insulin as a promise. And it is a promise. 100 years ago, it was a promise. And even today, it remains a promise. On that bright note, we'll conclude. And thank you for your patience. I really appreciate all of you staying here. And that's such a wonderful thing because I really mean that I'm so proud to be on the same stage with two of these most wonderfully accomplished human beings. Thank you so much.